Welcome to Radiologists, a podcast by University Medical Imaging Toronto, where we discuss the most interesting topics through the lens of Canada's largest medical imaging department. I'm your host, Satish Krishna. Do you know what the second most interesting thing which occurs once every 4 years? Well, the first one, obviously, is the league tape. But the second most interesting thing is the Olympics. Now, the Olympics is a spectacle like no other. It's where heroes are crowned. And when we think of Olympics, we think of great athletes like Usain Bolt or Michael Phelps. And when I ask you to name the world's greatest athlete, you're probably going to name one of them. However, did you know that the title of world's greatest athlete does not belong to either of them? In fact, every year it belongs to the winner of the decathlon. Now, the decathlon is a series of 10 track and field events. So the winner of the decathlon is good at all 10, but not particularly better than Usain Bolt at running or Michael Phelps at swimming. And therein comes the quandary and the age-old question: which is better, to be really, really good at one, or to be good at a wide variety of things, or a jack of all trades? Even the term jack of all trades is very interesting because when it was originally mentioned in the 1600s, it was supposed to be positive. He's a jack of all trades was a positive compliment. But in the 1800s, it was attached to the term jack of all trades, but master of none. And it kind of devolved into a derogatory term. But more recently, a lot of people have said that jack of all trades, master of none, but oftentimes better than the master of one. So there is this rise and fall of generalists versus specialists. And similar differences also happen in medicine and in radiology. And to speak about these differences in community radiology versus academic radiology, we have Dr. Aziz Qazi, who's interventional radiologist supreme, who was initially practicing in community, but has now moved to an academic center. Aziz, it's great to have you here.
Thank you for having me.
All right. So before jumping into the topic per se, how did you get into interventional radiology? Because once you get into radiology, the first thing you think of is, oh, you're just going to be looking at images and it's going to be more a diagnostic thing. Did you always want to be an interventional radiologist before you started, or did you change paths in the middle of residency?
Honestly, my journey to IR was very early on. It started, I met a man named KT Tan, and then the rest was history. So he's been my mentor since I was a PGY3. And then, along the way, I had some other great mentors like Arash Jabari and John Gachura. So they really kind of guided me towards the field. And I really enjoyed the procedural aspect, planning the procedures during the cases. So I think at a very early career, I think at the end of PGY2, PGY3, I was interested in IR.
That's amazing. We just had our previous episode on mentorship. And we were talking about how mentors shape the lives of the mentees. In your case, they literally shaped the direction you were going as well. And they kind of, encouraged you and inspired you to get into interventional radiology.
Oh, for sure. If I hadn't had those mentors and met you or Bayana, I would have been a body radiologist, right?
But,
yeah, but I met the right guys. Yeah.
Damn it, we missed you.
Yeah.
And then how did you end up moving to the community to start your practice?
Yeah, so I was very kind of inbred at the U of T culture. I did my residency at U of T, did my fellowship at U of T. And I always thought of myself as a community radiologist. I thought of myself as I didn't really know what that meant. And so near the end of my fellowship, there's a few community job opportunities. And by community, I mean, places that are not affiliated with a university. So these are places where you practice general radiology, but then you also have a subspecialty in interventional radiology. And I was fortunate enough to have a job in a place called Oakville Trafalgar Memorial Hospital. And I had some wonderful colleagues there. And that was the start of my staff life or my practice. And the community life was very much, 50% of it was diagnostic radiology. So where I'd be doing diagnostic rotations, which would cover everything from head to toe. I also did a lot of MSK there. So, they had some subspecialty MSK. I had an interest in MSK. So I would also rotate through their MSK rotations. And then the rest of my practice was IR.
Wow. Okay. That's interesting. So how long did you work in the community?
A year and a half.
Okay.
And about a year in, I realized, my initial goals was obviously when you're a student, you want to get out, you want to make money, you want to financially take care of yourself. And I didn't really give the academic part of my job any thought as a trainee, I'll be very honest. But then when you start making money and you realize, okay, in 30 years, how do I see my career? I felt that I was much more driven and focused towards IR as opposed to doing all the other stuff, right? So I really wanted to do more interventional radiology cases, higher end IR cases. And the rotation for me was great. I had a wonderful team and it was an amazing time. But for my own career and longevity, I wanted to do something that would kind of stimulate me more and allow me to really kind of hone those skills.
Wow. Okay. So then you decided to come back here. Is that it?
Well, I mean, the opportunity came up, so it wasn't like I wanted to come here. It was the opportunity came up, and I was fortunate that they offered me a potential job here. And then I thought long and hard about it, and I said, this is one of those opportunities that you can't turn down. It's at UHN, which is the largest IR program in Canada, and it's amongst the people that mentored me. So for me, when that opportunity came up, I never thought as a trainee I would even get that opportunity. So when it came up, I was very, very grateful and haven't looked back since.
Yeah, they would have been really sad to see you leave initially and very glad to have you back, I'm assuming.
Well, I think when I was a fellow, I never thought of myself as an academic person, right? Like I have a brother who's also an interventional radiologist. He has over 50 publications. I had one.
Okay.
Right? So I never thought of myself as an IR, as a academic IR, as a trainee. For me, I wanted to go to the community and do general diagnostics and IR on the side. But then when I went through the fellowship, I learned, wow, I really like this. This is something that I feel like I was born to do. And if I did this for the rest of my life, I'll be very happy. Right? And you don't realize that until you go through the motions, you go through the fellowship, and by the time you finish, it's too late. And so I was one of the lucky ones who got a second opportunity to really explore their passion. Whereas most people, they end up in the community, and the community jobs are very, very good. They're very comfortable. And so the inertia you need to move from there is very high. So they'll settle.
What are the main differences now that you've been in both places between the community job and then now your job here as an academic radiologist?
I think the main difference is community jobs are very tough because, like you said initially, you have to be, you're the jack of all trades, right? You're doing an emergency rotation where you're reading all the emerge cases. It can be anything from a shoulder MR to a brain MR to a foot X-ray, and your brain constantly is kind of moving between different cases, right, in different body parts. So it's not like in the academic world where, say, if I'm on angio, I'm just reading CTAs, right? I'm forced to think differently about each case, and it's high volume, and their expectations are very high. Each emergency department has their own time trackers, right? They want the reports in a certain period of time, right? You're getting those calls. You don't have a resident. You don't have a fellow. You're taking the calls, right? So I think I have the utmost respect for community radiologists because they make key decisions in patient care over 100 times in a shift, right? They don't have subspecialists they can rely on. A lot of the referrals coming into them are also from general practitioners that are using the radiologist as a guidance, right? They're the radiology reports as a guiding tool. So that radiologist makes a huge impact in a lot of different patients at one time. I think the downside of community radiology can be that it is hard for you to master one thing, right? If you want to do a really high-end case or you want to bring these subspecialty cases to your hospital, you are restricted by the support, right? If you don't have transplant at your hospital, you're not going to do transplant hospital. If you don't have hepatobiliary in your hospital, you're not going to do a lot of interventional oncology cases, right? So a lot of your practice is predicated on what type of specialty services are available in the hospital, right? Now, in the academic world, I think naturally, if you're in UHN, you're in academia, you have this natural curiosity that I'm trying this new procedure, does it work? Hence, you do the research, right? Like, so I inherited the AVM practice from Dr. Simons, and we have a new technique that we use to treat AVMs. And I never thought of myself as a research person, but naturally, I want to see if this technique works. Hence, we're doing the research project.
That's interesting.
Right?
What's the technique?
It's cryoablation for vascular malformations.
For AVMs?
For AVMs,
wow,
yeah.
Okay.
Yeah, so we've done over 50 cases now, and it's very effective, right? I can anecdotally say it's very effective, but it's meaningless until we publish the data and we showcase to the world that this is a very effective technique. And it's not that I feel pressured to do research. I naturally, because it's a technique that I'm doing, I naturally am curious to publish it and look into it and make sure that it's working.
That's amazing. You put it like that, because academic radiology is not fundamentally different that you're forced to do research or you're forced to do something different. But it's just that you naturally figure out that there is a better way to do it. And then you find that this is the systematic way to document that, to publish that, to analyze that, instead of just relying on anecdotal evidence and saying that one is better than the other.
Exactly.
So I guess like academic practice is just different than community practice, but it's not necessarily that you're forced to do something which you probably don't enjoy. It's just different levels of cases, different skills which may be needed. And coming to community practice, this is what's very interesting, because when I speak to most residents, they feel like, oh, in academic radiology, if I become an academic radiologist, I need to do this and this and this. I need to be teaching the residents. I need to be like preparing for rounds. I need to be like doing research. I don't want to do all of that. I just want to do my clinical work. And that's just easy for me, is what they think. But the way you put it, community radiology has its own challenges, because in academic side, I'm an abdominal radiologist. All I need to learn and keep updated about is just the abdomen. Whereas in the community side, you reported MSK, you reported abdomen, and then you are doing IR as well. So you need to put in a lot of learning or a lot of academic time into updating yourself. So in a way, I think the division is a bit arbitrary. It depends on where you want to allot your time to, and which is just slightly different. And the other thing I find is that I heard that you also started a tips practice when you were in the community center. So how did this start about? And was that not there initially there, and you kind of had to lead that from there?
Yeah, so when I was in Oakville, they had quite a lot of, they had a very robust gastroenterology program. They had some excellent hepatologists. So we had a lot of patients that were good candidate for tips, but we didn't have the tip service, right? So I think before me, they had done maybe 1 or 2 emergency tips, but most of them were being shipped off to UHN to be performed. But then when COVID started, the ICUs were shut down so that they weren't taking transfers. So because of that, the hepatologist approached me and said, hey, would you be interested in starting a tips program? And we had an amazing IR team in Oakville that, I personally just signed off the forms. They really did all the work to organize all the paperwork that goes into it. And we basically established a tips program. And what that means is, the way the patients are coming in, the referral is being assessed, the orders for the procedure, post-procedure orders, the ICU stays, collaboration with all the different doctors involved, the hospitalist, the ICU, hepatologist, IR. So all of that stuff needs to be sorted out before you start a program. Wow. And so we were able to do that. It was about a year. And then we did our first elective tips, and now it's going well. They've done another one. But all of that was predicated on the referring service, right? Mm-hmm. And I can say that at the time, people were a little bit concerned that we didn't have a hepatobiliary surgeon in-house, right? That was a concern that was raised. At UHN, I have every type of surgeon available, right? If I get into a complication, I can call the expert in so-and-so, and it's very reassuring, right? I have their support. In the community, you don't have that, right? So you have to, when you do cases that are more complex, you have to think about worst case scenario, where is my patient going to go? Or is the referring service comfortable managing this patient here? Do I have to transfer this patient out? So just, a TIPS program at UHN is just a routine case, right? Arash Berry does it in 2 hours, right? But when you take it outside of UHN, you put it in a community hospital, the operator may be very, very skilled, right? But there's a lot of other ancillary support services you need in place, and people need to be comfortable with that procedure before you can start. So that's what really takes a lot of time and effort. And you only have so much bandwidth to do one type of procedure a year, right? You can't be starting TIPS and then fenestrated EVAR and then cryoablation, right? The hospital also has limited resources. So you have to be very, very careful in which programs you select. And more importantly, everybody in the hospital, not just the interventional radiology department, but the diagnostic radiology department and the referring clinicians all need to be on board and supportive.
Wow, that is very interesting. It almost seems like in community, you have much more responsibility in terms of direct patient care, as well as much more responsibility in terms of bringing essential services to the community and setting up programs there. It's almost the same thing here. In academic radiology, your responsibilities are to create cutting-edge new techniques and programs which aren't established as yet. And then, in terms of patient care, it is training the next generation to be better. So at the end of the day, I kind of feel like the responsibilities are going to be there no matter what. It's just like a slight difference in one versus the other. But for you specifically, what made you make the shift? Was it an allure to something? Was it an allure to research? Or why did you decide at your point that you wanted to shift after a year and a half in the community?
Yeah, I mean, for me, when I got a phone call and they said, would you be interested in this job? Like I said, I never thought that would even be a scenario for me, right? Because I never thought of myself in that situation. But it happened to be at the right time where I was getting, I don't want to use the word bored, but, I felt like I had kind of peaked a little bit in terms of my practice.
Wasn't challenging enough for you?
Yeah, and I wanted to do more IR. I wanted to do more cases of IR. I would have done angio 5 days a week, right? At that time. At this time, I'd probably do 3 days a week, 3 or 4. But at the time, it was like 5 days a week. I want to do more angio. And so that's what, and then when one of my mentors calls me and gives me this opportunity, for me, it was a no-brainer because, I knew I could always go back to the community, right? Like I was not worried about diagnostics, like my diagnostic skills, but I knew this opportunity only comes up once. And, like if you say no now, it's going to alter the trajectory of your career for the rest of your life, right? So I wanted to make the most of that opportunity. And so that's why I wanted to come here.
Looks like you've done amazingly well after coming here because you've established the cryo service. You've taken up Dr. Simons. We also had Dr. Simons on the interview, and he was really proud of the fact that every single one of the people he hired after him were better than him, at least in his own mind. So he takes really great pride in finding the right people to succeed him, and looks like he has done awesome. But speaking of community versus academic, is there any other difference in terms of culture in the two places in general? Because you worked in both places. Did you find anything fundamentally different?
Yeah, I mean, again, community is also very variable depending on which hospital you're going to work at, right? A lot of the culture and environment is predicated on your colleagues, right? Okay. So at UHN, the IR department, we're very, very close. I have amazing colleagues, people I can rely on for help. These people have mentored me. There's not a day goes by where I don't learn from them because, at Toronto General, we have these angio suites and there's usually 2 or 3 of us together that I can show cases. We can bounce back ideas. So it's a very collaborative environment and it's very educational for myself as a younger staff. In the community, sometimes the issue is that, you may have a couple different sites that you're covering, but then, you're by yourself, right? And it's very difficult in your first couple of years to be put in that situation, right? You do complex cases in the community. Some of the most difficult cases I've seen are coming to those community radiologists because they're on an emergency basis and they're by themselves, right? So the ones that have a good network around, some of the older IRs around that they can call upon, they're the ones that do well. And then if you don't have that around, then it's more difficult, right? So I think the culture is really predicated on your colleagues. But having said that, my brother is a community radiologist, and for him, he's flourished. He's done very well because the older IRs really took care of him, right? Okay. And I felt the same way, right? So I think that's a very important part of your kind of development.
So overall, it seems pretty balanced, right? Like there are pros and cons of each. But why do you think that a lot of people, a lot of residents, after finishing their residency and after finishing the fellowship, primarily opt for jobs in the community? Is it primarily driven by the financial incentives?
Yeah. I mean, there's a few reasons for that. First of all, there's just more community jobs available than academic jobs, right? So when a IR fellow finishes, there may be one academic job for every like 3 or 4 community jobs out there, right? Okay. So just based on the volumes, you're more likely statistically to have a community job. I think on the most part, community does offer a better work-life balance. I'm answering emails till like 7 p.m. Right? We have a clinic that we run, so you're answering emails for that. There's research. There's all these academic things that you end up doing. There's things around your cases, about planning. So there's all these ancillary things that you do that some are clinical, some are non-clinical, right, with the academic practice. But in the community, when you're done your shift, you're done your shift, right? Unless you have a specific role in the department, say you're the lead of IR or you're the treasurer of the group, etc. Other than those jobs, you're done your shift, right? So it's much more balanced in terms of work-life balance. And on general, you do get paid more in the community. And I would say that when I was a trainee, they used to say the smartest people go into academics, but I can tell you the smartest rads I know are in the community.
Okay.
Right? Right? And these guys were very academic, they were very academic, very, very knowledgeable. They all went to the community because of the fact that of the work-life balance. But I do think that as radiology is changing, now it's not just the job that people it's not just their primary job. A lot of people have secondary jobs. So it's not just the normal community job that they're reading for. They're reading for other groups. They're reading for clinics, right? So the work-life balance is kind of slowly fading away as the cost of living is going up.
Oh, yeah. Okay.
Yeah.
So you're saying that a lot of smart radiologists end up in the community, and maybe, just because a lot of community hospitals are not in downtown Toronto, which means that you don't have to buy a house in downtown Toronto.
Yeah.
And it's actually probably the smart move to not buy a house here and buy somewhere else.
Yeah. I'll say this again on camera. The smartest radiologists I know are in the community.
Wow. Okay.
Yeah. Yeah. Very, very smart.
Good to know. So in terms of like work-life balance, one of the common things said about a community job is that the volume of cases they have to read and volume of work they have to do is significantly more than an academic counterpart. So how does that factor into work-life balance? Because I do know a few fellows who finished here and then went to the community. And they said that quite a lot of their Sundays and Saturdays were spent in trying to catch up from the week prior.
Yeah, again, it depends on what type of practice they end up going into, right? So if you go into a very high volume practice with not a lot of radiologists that, that really focus on volume, that'll happen. The other thing to remember is that the cases that you're reading at UHN are on average much more difficult than, abdominal pain through the emerge. But having said that, some of the community practices, you're getting very advanced disease through the emergency. But I would say on the most part, your abdominal MRI that you end up reading, that, has been ablated multiple times, has had TACE, et cetera, new immunotherapies in place, right? Those are going to be more complex than the average CT that's being done in the community. So just based on that, you are able to read a higher volume because the pathology may be less, or the complexity is less, right? But I think as our population starts to grow, that may change a little bit. But for the most part, that's why in the academic world, the cases are more complex, so you're not reading as much.
So you've declared that the smartest radiologists are in the community. What do you think needs to be changed to attract smart radiologists to come in academia? So both are equally important, but you find that in academia, you have the ability to create something new, and you have the ability to teach and impact not just the life of your patients, but countless patients after you in terms of your teaching. So we do want a lot of smart people coming into academia. What do you think needs to change?
Yeah, I think so. Someone like myself, like where I, was generally, I was very attracted to the IR, and I had the right framework and I had the right mentors that were available for me that guided me towards that field and supported me. And, for myself, for sure, the income was a big hit, right? Like financially, that was probably the biggest reason why I thought twice about the job, right? So nowadays, you can do other things to supplement your income. You can read outside, you can read clinics. We all go to Sudbury and we work there as well, right? So there's all these other opportunities that are available. And I think it's important to have a frank discussion with fellows and residents about the financial aspect of radiology, because at the end of the day, you have to pay your bills. And when I was a resident, no one ever talked to me about the financial side. No one told me how much radiologists made, how much bills were, how much a house costs. I moved here from Calgary, right? Like I didn't realize all these things. But I wish someone would have, right? And no one does. And I think it's important to have that discussion. And it's also important to have a discussion that just because you work in academia doesn't mean you don't have other opportunities to supplement your income.
Okay.
Right? I think that's a very important point. I think if more and more people realize that, an academic job will be much more attractive to them, right? Whereas in the community, when you go to a center, you're going to make an X amount of dollars, right? So people are attracted to that. It's usually more than what they make in the academic world.
Amazing. I think you hit the nail right on the head, because when I moved from Ottawa, it was such a huge shock. The difference in just the rent from Ottawa to Toronto, which is so significant. And I wasn't prepared for that. So you're totally right that maybe having these financial discussions, there is this secrecy around how much people make, and people don't want to talk about that. You're right. We need to be more frank. And that has to go to fellows and residents to have frank discussion. And I guess your next point about the ministry and the arbitration, they should try and make sure that there is not a significant income disparity between the both, because if this divide continues, we're going to lose brighter radiologists to the community, and we might not be able to retain the best radiologists in an academic practice. But how do you think that things are going to look in future now that we have AI coming up?
Yeah.
Who do you think is going to be benefited the most? Who do you think in long term would be affected first? Is it going to be the community radiologist who has a broad skill set? Or is it going to be the academic radiologist who has a narrow but like a very, very deep skill set?
Well, first of all, I think the extreme end of AI replacing radiology, if that happens, they'll probably replace most of medicine.
Yeah,
okay. So now to supplement, I think it'll help both. Certainly, when you're a general radiologist, right, and there's basic tools that you can use that AI can, like detection, right? Detection is a fundamental function of radiology. And AI can certainly help with that, right? And then you fall into the interpretation aspect. Now that is where, if you're a Satish and you're a abdominal radiologist at UHN, your interpretation of a renal cancer is going to be much different than someone who doesn't have the same training or fellowship or experience, right? And then you may offer more insight into that lesion and its treatment than a general radiologist, right? So that at that level, I think the academic radiologist is certainly going to have their role to play. So I think in terms of detection, AI will definitely help the community radiologists because they have to go through more volume, right? But for IR, I think we're ways away from computers taking over our jobs, right? Thankfully, right? But I think AI will definitely help us as well in terms of at a system level of us kind of coordinating our plans for our cases, and just the workflow of IR as well, right? So there's a lot of input that AI can have. But I think in terms of our actual practice, I think we're still several decades away from AI replacing interventional radiology.
Wow. Okay. So your solution there is just become an interventional radiologist. It's not going to replace us.
Well, it's not. I mean, procedural specialties are harder to replace,
Absolutely,
right?
yeah.
But like I said, I think that if we come to a point where AI is quote unquote replacing radiology, they're going to be replacing a lot of fields in
Absolutely,
not just medicine fields, period, right? So I'm not too worried.
Great. So if a resident, or not a resident, but let's say if the medical student wants to get into radiology, I guess your advice is going to be, to steer him into interventional radiology, because now you actually even have a residency program in many places. But let's say that you have a resident and a fellow who's already have these specialties set up, but now they want to decide between a community job versus an academic job. What advice would you give to them? And how do they need to approach this decision making? Is it logistics, or is it something fundamental about them? Are there personality traits which fit one over the other?
Yeah, I think the first thing I would say is if you can work at a center that you genuinely like the people that you work with, that's probably the single most important. The rest doesn't really matter, right? If you enjoy going to work and you work with colleagues that are supportive, and I had that in Oakville, and I have that in UHN, right? So I can kind of say that tick mark was met, right? And then the next thing is if you generally have an interest in a special subspecialty in radiology, say MSK or cancer imaging, et cetera, right? And you can find that niche in a community practice, then for the most part, you're going to be very happy, right? So in Oakville, for example, there's a lot of orthopedic surgeons. So there is a rotation for MSK, right? Okay. Just like maybe in Trillium, there's special oncology people with oncology training that are reading all the difficult oncology cases, and so if you can find the little niche, and the hospital and the radiology group support that, then you'll be fine, right? And then I think those are probably the two most important things: the interest and then the colleagues. And then the money, I would say that every billing code is the same. So if someone is making more than you, they're working more than you, they're reading more than you, right? There's no magical billing code that is specific to one hospital over the other, right? So just know that if someone is making more money, they're working much harder, right? And money is a direct function of time invested, right? So if you want to make more money, you can work at clinics, you can do work on the weekend. It's always available to you, right? Yeah. But I would say that for myself, there were days that I was bored. I've never been bored at UHN, right? I have a very, very high job satisfaction. And every day, I feel very blessed and lucky to work here because of the cases that we do and the colleagues that I'm surrounded by. Whereas, when I was in the community, there were some days that I was bored, right? So that doesn't happen.
Wow.
Yeah.
That's amazing advice, because to summarize it all, as long as you have people around you who you are happy with, as long as you find the work challenging and keeping you engaging, as long as you have avenues for professional satisfaction, that would be the right place for you. Doesn't matter if it's a community or if it doesn't matter if it's academia. You just need to find if something fulfills all of it. If you really love patient care, the challenge, the diagnostic aspect of radiology in a broad variety of challenges, maybe a community job would be best for you. If you love teaching, if you love mentorship, if you love crazy challenges in a very, very tiny area, then maybe an academic job would be great for you. And that, I think, kind of summarizes the whole jack of all trades, master of one, but oftentimes master of none, that adage. Because there isn't a clear answer. Even when you ask to experts, for example, Bruce Lee once famously said, "I fear not the man who had practiced 10,000 kicks once, but I fear the guy who has practiced one kick 10,000 times." And he seems to be a proponent of speciality in which doing a very tiny thing over and over again. But on the other hand, Bill Gates, who we think is a specialist, he recently recommended as one of the top reads of the season a book called Range, Why Generalists Triumph in a Specialized World. And that's a book by David Epstein. So this debate rages on. At the end of the day, there is no correct answer. Or in other words, there is a correct answer in which either answer is equally right. You just need to find what suits you, what suits your family, what keeps you happy, what keeps you professionally motivated, what makes you a better radiologist every day. And that's the direction you want to take. And if you want to look towards the academic side of things, you're always welcome at the largest medical imaging department of Canada, University Medical Imaging, Toronto. Ladies and gentlemen, that was Dr. Aziz Qazi, interventional radiologist extraordinaire, and me, your host, Satish Krishna. See you on the next one. You were listening to Radiologists, a podcast by University Medical Imaging Toronto, the largest medical imaging group in Canada. Produced by Ina Levchuk. Learn more about us at universitymedicalimagingtoronto.ca and follow us on social media at Imaging Toronto.